Okay. You see all speakers here. It's 3 o'clock already. Okay, ladies and gentlemen, as we are about to begin, please allow me as the moderator today to announce few housekeeping notes. First, I would like to seek your cooperation to keep your mic mute throughout the program, except during the Q&A session later. Second, the Q&A session will be at the end after all 6 speakers already delivered their task, their talk. You may ask verbally later, or you can chat through the chat box. Dr. Samir?
Yes, Doctor.
Okay.
Assalamualaikum.
Yeah, salam. Just started. All speakers only have about 15 to 20 minutes for their presentation, and the Q&A will be only about 10 to 15 minutes before we end the program today. Okay, inshallah. Assalamualaikum and good afternoon to Malaysian audience, and good morning to our colleague from Palestine. It's 9 morning that side. I'm Associate Professor Dr. Muhammad Hasni bin Jaafar. It's my pleasure to be the moderator for the webinar today. Before that, I would like to thank the committee that made this happen, Prof. Dr. Zalaha Maisa, Associate Professor Dr. Rosita Hood, Associate Professor Dr. Asmawati Muhammad Nawi, Dr. Azam Abu Habib, Dr. Samir Abu Zer from Palestine, and our technical officer, Mr. Zazman Wahab. Thank you very much. So welcome to this international webinar, COVID-19 Pandemic Malaysia, Palestine 2020. On behalf of the webinar committee, I would like first to extend our appreciation, particularly to our Dean, Faculty of Medicine, UKM, Yang Mulia Professor Dr. Raja Effendi Raja Ali, and the head of Department of Community Health, Faculty of Medicine, Associate Professor Dr. Muhammad Raiza Hassan. We also like to thank you all here online and those who watch through Facebook for taking time off your busy schedule in this COVID-19 pandemic to join us today in this webinar. Inshallah, we all will learn a lot from all these 6 distinguished speakers today. To start the webinar, we are pleased to introduce to you Dr. Badru Hisham Abdul Samad from Faculty of Medicine and Defence Health, National Defence University of Malaysia. A little bit about Dr. Badru Hisham. He obtained his MBBS from University of Malaya in 1994. And then he pursued with a Master in Public Health from University of Glasgow, Scotland, 2003. And he obtained his Diploma in Medical Strategic Leadership from Academy of Health Science, US Army, 2009. He's one of the well-known public health experts during the COVID-19 that served the country and also advised several government agencies like National Security Council, National Disaster Management Agency, and many more. Without further ado, I present to you Dr. Badru Hisham from Malaysia to deliver his talk. Dr. Badru, mic yours.
Thank you very much, Associate Professor Dr. Muhammad Hasni. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and good morning to all the colleagues. First and foremost, I would like to thank the organizing committee. Consists of those from the Department of Community Health, Faculty of Medicine, National University of Malaysia or University Kebangsaan Malaysia. Secondly, the Palestine Ministry of Health, and last but not least, the Islamic University of Gaza. So thank you very much. So this afternoon, I'll be sharing with you for the next 15 minutes or 20 minutes or so on the Malaysian experience, particularly on the lessons learned so far while we are still struggling and handling the COVID-19 pandemic in Malaysia. Right, I'll try to share my slide with the audience. Okay, I'm sharing now. Can you see my slide, Dr. Hasni?
Okay, yeah. Can you make a slideshow?
All right, we will do. All right, is that okay now?
Okay, great. Okay, can continue.
Okay. Right. This is the latest COVID-19 statistics globally that I got from the Johns Hopkins University. So obviously we can see that now total COVID-19 cases that have been reported worldwide just over 56 million, okay, with 1.3 million deaths. And obviously we can see that the USA is leading the numbers in terms of cases as well as deaths. They contribute to about 20% or 1/5 of the global cases as well as COVID-19 deaths. This is Malaysia. We located in the Southeast Asia. So you can see here that we have Thailand to our north, we have Singapore to our south, we have Indonesia to our west and east on the Borneo Island. We have the Philippines on our northeast. And you can see Malaysia is a small country in Southeast Asia, but we are surrounded by oceans, by sea. So you can imagine that we have really a challenge in controlling our borders. Just a very brief demographic of Malaysia. In 2019, we had about 32.6 million population, whereby that almost 30 millions are those Malaysian citizens, and the rest, the non-citizens, about 3.2 million. We have three main ethnic groups in Malaysia. We have nearly 70% of the Malays, as well as what we call Bumiputras. Bumiputras basically are those aborigines as well as indigenous in Sabah and Sarawak, both two states on the Borneo Island. And then we have a Chinese ethnic group, consists about 23%. Next, the Indian population, about 7%, and the rest a very minority of other ethnic group. And we can see as well our demography in terms of age. So obviously, nearly 70% of Malaysian population are those within the productive group, aged between 15 to 64 years old. And our young population, our children, consists almost 1/4 of Malaysian population. Right, this is the latest figures, statistics of COVID-19 that we recorded yesterday as of 18 November 2020. So Malaysia just surpassed 50,000 cases of COVID-19 so far, reported to the Ministry of Health Malaysia. And with 322 deaths at the moment, which is equal to 0.6% of case fatality rate. If I recall, in fact, even though the number of deaths is increasing, but looking at the total number of cases, our case fatality rate actually is decreasing. Previously, we recorded about 1.7, 1.4% of case fatality rate, but as of yesterday, it was down to 0.6%. Okay, and out of these 50,000 plus cases that we have so far, about a quarter of our cases are still active cases, meaning that they are still being treated at our hospitals and they have a potential of infecting others. Right, this is a snapshot of the phases of so-called lockdown, or what we call in Malaysia as movement control order, the MCO. So the first movement control order enforced by the government on the March 18, 2020. And we have 3 phases of MCO. And then we came to what we call the conditional MCO, which was more relaxed, starting 4th of May this year. And starting 10th of June, actually, Malaysia went into the recovery MCO. We were in the recovering phase, but unfortunately, there was a spike in COVID-19 cases in Malaysia, especially starting in September this year. So at the moment, most of the states in Malaysia now to be put under the CMCO, the Conditional Movement Control Order. So if my calculation is right, today is actually the day 247 that Malaysia is experiencing this so-called lockdown starting from the 18th of March this year. Here you can see clearly from the graph, well, we started our very first case actually notified and reported from Johor State Health Department to the Ministry of Health on the 24th of January this year. The very first wave was very small in number actually, so just about 20 plus cases. So what happened initially, we detected positive cases. 3 out of 8 close contacts, Chinese nationals who came to Malaysia, to Johor, which is the southernmost state of Malaysia, from Singapore through the Johor Causeway, we detected as positive COVID-19. 3 of them, 3 out of 8 close contacts to the index case of Chinese national diagnosed and treated in Singapore. So that was the very first case. Then there were hardly any case detected after that. But then somewhere at the end of February and early March this year, I'm sure fellow Malaysians could recall that we had rather large gatherings, religious gathering in Sri Petaling Mosque among the Tabligh Jemaah group. And unfortunately, there were COVID-19 cases among them. And once they finished their congregation, they went back to their respective states nationwide in Malaysia. They brought along the COVID-19 and introduced to new clusters nationwide. So that was where we recorded a second wave during our COVID-19 pandemic in Malaysia. In fact, this Sri Petaling cluster, it went to until 6 generations of COVID-19 cases. Yeah, somehow, Alhamdulillah, we managed to settle down the cases. Okay, accordingly, these are the phase of the movement control order, especially following the COVID-19 clusters, the 6 generations, following the Sri Petaling Mosque congregation back in end February and early March this year. So that's where the Malaysian government imposed the first movement control order, which was rather strict in implementation. Okay, but then after the clusters were subsiding and the cases were coming down, then Malaysian authority put quite a relaxed MCO, becoming what we call the conditional movement order, control order, starting from 4th of May. Yeah, and you can see clearly from the graph, we recorded hardly any cases of COVID-19 throughout, after mid of June 2020 until end of August. Okay, so that's why the government then put a more relaxed implementation, what we call the recovery movement order. But as I mentioned before, unfortunately, we recorded a spike in COVID-19 cases. And well, it started in Sabah actually. We recorded few of the COVID-19 cases in Sabah state. Sabah is one of the 2 states on Borneo Island. And it was made worse with the state's election that took place somewhere in September, this year. So at the current moment, what we are facing now actually really a spike, a surge of COVID-19 cases, in particular in Sabah states. But then it has spread to the Klang Valley, meaning the Kuala Lumpur, the Selangor as well as Putrajaya areas in Peninsular Malaysia, and even some of other states in Peninsular Malaysia, whereby a number of index cases of the new clusters in Peninsular Malaysia, in many states in Peninsular Malaysia, were related to the Sabah clusters of COVID-19. This is the recent graph until yesterday. So the government has imposed the recovery MCO, but it stopped short, whereby on the 9th of November, the Malaysian government declared that all the states in Malaysia, except for Peninsular Malaysia, for Kelantan, Pahang, and Perlis states, were imposed under the conditional MCO. So it is much stricter, but not as strict as the MCO in the very first phase of COVID-19 in Malaysia. You can see from the graph, actually, for the past 5 to 6 days, we recorded 4-digit numbers each day. More than 1,000 cases, 1,000 plus cases for 5 days. But yesterday, it came down almost halved. So we hope that this is a good sign for the next days to come in Malaysia. Right, I'm afraid this is in Malay language, but this is the what we call the SOP, the Standard Operating Procedure, for the conditional movement control order imposed in many states in Malaysia. What the people can do, what the people cannot do, and so on. And this SOP actually being coordinated by our Malaysian National Security Council, after the endorsement and gazettement by the Ministry of Health Malaysia. Right, now I just go very quickly to some of the lessons learned by Malaysia. There are many lessons learned actually from this pandemic COVID-19 in Malaysia, but I summarize into 7 Cs, 7 Cs components, namely the commitment, the control measures, coordination, communication, compliance, continuous care, and continuity plan. So we shall go one by one very briefly. The number one, I would say, the lessons learned then and very important lesson is that the commitment, the full commitment by the government, the political will by the government. Well, it was rather a challenge actually. When we experienced the first wave of COVID-19 in Malaysia, actually, we in Malaysia was in transition in terms of the government, the ruling government during that time in late February and early March 2020. But, well, I would say that we'll be very grateful to the newly appointed government, whereby that the government was very quick in imposing the MCO, so-called the lockdown for Malaysia. So on the 18th of March, simultaneously, all the national borders to our neighboring countries and even to other countries as well have been closed totally. So with travel ban being imposed immediately, okay? If I were to recall, before the new government took over, there was a bit of hesitation actually to close the border. For example, in Sabah, because we know that Sabah was receiving many tourists from China. So at the time, there was still no order to close the border and to travel the ban from the Chinese tourists. Well, we know very well, obviously, that this COVID-19 pandemic started in Wuhan, okay, started in China, and Malaysia, especially in some of the popular states, namely Sabah, namely Penang, we received a lot of tourists from China back then, pre-COVID-19 phase. And good that the Malaysian government really took control on handling this COVID-19 enforcement and implementation. And you can see now the security forces, namely the police, the Royal Malaysian Police, and even the Malaysian Armed Forces, the Army, the Navy, and so on, they were being pulled together to enforce this border control. Again, if you recall that I mentioned that Malaysia is surrounded by oceans, by seas, so it is really a challenge until today for the security forces to man our waters to stop, the illegal influx people from neighboring areas. Okay. Not only that, you can imagine that for those who succeeded, to came ashore to Malaysia and then came to our land, many of them try to hide in forests, for example, So some of people may not know that not only the armed forces, namely the police and the military, but also the forestry department, they also involved to help and apprehend those that came into the country illegally in our forests. Right, next, control and countermeasures. This is very obvious. Well, I would say that, well, unfortunately or fortunately for Malaysia, because we have been handling a number of outbreaks, I think at least for a decade or two, We have experienced SARS, we have experienced Nipah encephalitis outbreak, we experienced the H1N1 pandemic flu in 2009. So those were experience that we gained from the previous outbreaks. So in terms of the COVID-19 pandemic, so basically Malaysia, in particular the Ministry of Health Malaysia, were more prepared in handling this kind of infectious disease outbreak. And we have many resources in place nationwide. Just an example, all our international point of entries, namely the airports, the seaports, and the ground crossing, we do have the health team, the health personnel that man all our international border. So just a matter of mobilizing and reinforcing the health teams at the border that help really very quick in controlling our borders from the influx of COVID-19 from abroad. Okay, and in terms of hospitals, the Ministry of Health Malaysia, we have a very big network of government hospitals, public hospitals nationwide. So what happens during this COVID-19, only the government hospitals that handling and managing the COVID-19 cases, but we let our colleagues from the private hospitals, from the university hospitals to handle those non-COVID-19 cases. So a number of non-COVID-19 cases were transferred to other hospitals so that the Ministry of Health Malaysia's hospitals can concentrate on treating our COVID-19 patients. And not only that, there are a few other infrastructures that are being converted into what we call the low-risk treatment centers. Even though that the COVID-19 patients have cured, so-called, and have been discharged, have already been negative from the COVID-19 testing, but some of them we still put under what we call the low-risk treatment centers. There are also some field hospitals that will open up, meant for even Malaysians and non-Malaysians cases, depending on the sites. For example, here at the moment in Sabah, there are also field hospitals manned by the Malaysian Army to help the Ministry of Health Malaysia handling the COVID-19 cases in the public hospitals. Okay. NADMA, the National Disaster Agency for Malaysia, really helped the country, whereby that they were the one that coordinating and managing all the quarantine stations nationwide. So initially, the government gazetted many hotels nationwide, and then some of the learning institutions as quarantine stations throughout the country to cater for 14 days for those close contacts, those without symptoms and negative COVID-19, but to put under quarantine for 14 days. Those with COVID-19 positive, even though that they are asymptomatic, all of them are being admitted to the government hospitals. In addition to that, some of the areas with high transmissible areas, transmissible of COVID-19 cases are being put under Enhanced Movement Control Order, EMCO. This is much more stricter implementation by the government. So you can see here the picture where the MCO area will be really guarded by our military and police personnel 24/7, and with the barbed wire to ensure that they won't escape from this enhanced movement control order areas. Right. I just mentioned briefly just now the role of our NSC. So really, the NSC is the one that coordinate all the control measures, all the COVID-19 activities nationwide. Okay, and NSC as well, the one that will produce, endorse the all the SOPs by the government after being reviewed by the Ministry of Health Malaysia and after being gazetted by the Director General of Health. Okay, and really we can see that many government agencies that really work hand in hand. Even I think some Malaysians may not be aware that MITI has been playing a very big role in coordinating many industrial players, especially in coming up with the SOPs right from the CMCO phase. Yeah, so MITI was the one that roping in and calling the players, the representatives from agencies and even from the industrial association and societies to come up with sound and practical SOPs with advice by the Ministry of Health Malaysia. And other departments as well. There are lists of government departments and agencies as well as NGOs that help the country in mitigating this COVID-19. The Fire Rescue Department helping in environmental sanitation, the Social and Welfare Department. So obviously they are the one that coordinating the aids to the population affected, mostly affected by this COVID-19. And even the Religious Department that helps in coming up with SOPs on prayer congregations and funerals. Well, what I meant with communication is more of the risk communication. This is very important lesson learned. In Malaysia, if I may recall, during the early phase of COVID-19, really there were a lot of fake news, that were going around through the social media, and that has created some panic environment, anxiety environment from the population. So it was very important that the very top level of government to handle this fake news and to address these issues very quickly. And if you can see, our Minister of Health, Director General of Health Malaysia, Tan Sri Dr. Nur Hisham, well, since February this year, he's on air delivering the press release and updates every day. I think only a couple of days that he was, missing, so-called, from the daily press release. But other than that, every day, for more than 200 days now, Tan Sri Dr. Nur Hisham, our DG of Health Malaysia, as well as the Senior Minister, Datuk Sri Ismail Sabri, the Minister of Defence for Malaysia, every day will give the press release to Malaysians, to all Malaysians. This is very important to allay the fear, to allay the anxiety from the populations, and to deliver the truth, the correct information with regards to COVID-19 in Malaysia. Right. The next C is compliance versus complacency. Complacency is very dangerous. Actually, we have been talking about the danger of complacency since the beginning of COVID-19 pandemic in Malaysia. But obviously, you can see what happens starting September this year, and it was made worse with the the Sabah election, where people started to forget about the strict COVID-19 SOP. So some of them were not wearing masks, you know, and then some of them were congregate in very close distance. So this has contributed to the spike of COVID-19 cases in Malaysia of late, unfortunately. So in terms of the SOP, well, everyone, each and every one of us need to really adhere to the SOP to ensure that there'll be no more spike happens in the near future. Continuous care, this is quite, hard to balance sometimes when we were to protect lives as well as the livelihood of Malaysians. Yes, the MCO, the government has to impose the MCO, the CMCO and whatnot, you know, in order to protect lives. But at the same time, we have to ensure that the people can go to work so that they can earn money and, you know, to continue their daily life. But on top of that, it is good that the government has announced billions of dollars, actually, billions of Malaysian ringgit as what we call the economic stimulus packages to help the needies, to help those badly hit by this COVID-19 pandemic in Malaysia. And not only that, if we look at the recent budget 2021 as announced by the government, 1 billion Malaysian ringgit is allocated just to manage this third wave of COVID-19 in Malaysia. And in addition to that, we have many NGOs, many social activists that also give their hands in helping the needy and the poorest badly affected by COVID-19 pandemic in Malaysia. Continuity plan, this is the last but not least of the 6 components among the lessons learned by Malaysia. The continuity plan, the business continuity plan, this is very important. We learn a lot from this COVID-19 pandemic. Even our webinar right now is as a result of COVID-19 pandemic worldwide. So we have to make use of what available technologies now, and we have to improve this for the better usage in the future. And not only that, we also obviously can see that each and every country has to be self-sustainable, self-sufficient, self-reliant, you know, because when the outbreaks happen globally, every country needs to use their own resources. So they can't afford to give extra resources to other countries. So we have to come out with our own in terms of medical treatment, PPEs, antiviral vaccine, and so forth. And another big challenge is the COVID-19 free transportation. So we know that now all the airlines are grounded. So this is another challenge, how to ensure that our aircraft, our aeroplanes are being able to fly again, but at the same time that it stops, spreading COVID-19 throughout to other countries. That remains a challenge. I think with that, thank you very much. I get back to you, Dr. Hasni. Thank you.
Okay, thank you, Dr. Badrul. Thank you very much for your very interesting talk about the lesson learned from Malaysia. Again, please remind the speaker to stick to the time. I did send a chat, so please follow it. It's about extra 5 minutes. Okay. So I saw there's a few questions, but we keep that until the end of our webinar. Yeah? So thank you very much, Dr. Badrul. I keep online till the end. Thank you very much. Okay, our next speaker is from our colleague from Palestine. Please welcome Dr. Azam Abdul Habib from the Islamic University of Gaza, Palestine. Dr. Azam here?
Yes, I am.
Okay, great. Okay.
Yeah.
Okay, short info about him. He's our UCAM PhD scholar, postgraduate, so graduate in the water resource engineering, who graduated in 2013. He's actively now as a consultant in the water resources and crisis management field in Palestine. He teaches emergency management and shelter and displaced management in several research in the COVID-19. And he also wrote several books and articles in disaster management planning, response and recovery with a recognized international publisher. Okay, because we don't have enough time, without further ado, I invite Dr. Azam to share lesson learned by Palestine during this COVID-19. Okay, Dr. Azam, please.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah, and good afternoon to the colleagues in Malaysia, and well, good morning to the colleagues in Palestine. As you know, we are now like 9:30 a.m. And I'm also thankful to Dr. Muhammad Hasni for moderating this webinar and also for organizing as well. And I thank all colleagues in UKM, and I do thank our colleague Dr. Badrol for his fruitful presentation. Let me share mine quickly so that I can stick to the time. Okay, so what I'm going to talk about is the lessons learned by Gaza in particular in Palestine about, of course, about COVID-19. I'll talk in like 4 points. Mainly, I will give some background about COVID-19 in Gaza and in Palestine. And then I will talk about the overall response, measures and actions. And then thirdly, I will give some heads up about where do we stand. And also finally, how to adapt in the light of the WHO adaptation strategies that was established in April this year about COVID-19. So as an introduction, just to give you some heads up, this is where is Palestine in the map. Of course, some unfortunately see it as Israel because we are still under occupation. We are the only place in the world under occupation now. And so instead of seeing Palestine here, you can always see in the global maps 2 parts, Gaza Strip and West Bank. Gaza Strip is siding like almost beside like to the Mediterranean Sea with the borders with Egypt in the south. And to give you also some information about Gaza, it is 365 square kilometer with nearly 2 million living in. One of the most dense areas across the globe. As an introduction related to the COVID-19, the first 2 cases were discovered on 22 March this year, coming back from the Rafah crossing point from Egypt. And then by 2nd May, there were still only 17 cases confirmed, 13 of whom were successfully treated. So by May, we were still like somehow having no inside cases, only cases for the returnees coming from either from the north, from Israel, or from Rafah from the south. Until sadly, 24th August, where the first inside community cases were discovered, leading to imposing, of course, full lockdown by local authorities in Gaza. Ever since, numbers continue to increase in daily basis from tens to hundreds. I recall that yesterday number was like, I think 600 plus cases recorded, and I think today it will be either the same or perhaps more. Just to give you also some numbers, as I mentioned, more than 2 million living in a fully besieged piece of land of 365 square kilometer for the past 14 years already, with an average of 5,500 person per square kilometer. So you can imagine how dense the place is. Due to this siege imposed by the Israeli authorities since 2007, limited resources and complicated political situation is there due to course, the occupation, and also, unfortunately, the internal dividing between among the Palestinians. Currently, what we have is 27 hospitals in total, 13 of which are public or governmental hospitals, with only 1,500 bed total capacity, 100 of which are ICU beds. The number of staff that we have, public medical staff, including doctors, nurses, and others, is around 8,000. So you can see numbers are really concerning. This is all the resources that we have, and it's unfortunate that it is even difficult to extend or to bring from across the globe, because, as you know, with COVID-19, every single doctor in the globe is busy with his own or her own state and family and area. So it is not a one place crisis, it is a global crisis. So everybody tends to depend on him or herself. Secondly is the measures that we have or we had to face this pandemic. So we don't have waves. What we have is that a period where we have only cases discovered in the borders and then quarantined, which is the period from March to August. And then from August until now, what we have is inside the community cases where PCR tests are made, and then randomly and sometimes with a focus in an area or two, just like the rest of the world. So from March to August, we had a compulsory quarantine for all returnees with PCR tests for all of them. We have a limited period of full lockdown that ended up by July to August, in terms like gradual lifting starting from 1st August 2020, somehow restoring all activities to normal, except some activities like education, academic, some like public big activities were not restored. Now, going through from August to November, we still have compulsory quarantine for all confirmed cases. Now, I think by last week, changed to home-based approach, because the government is very much exhausted and the capacities are running very low. So we are now moving to the home-based approach. It is risky, but it is an unfortunate, but this is what we have. We had full lockdown, then gradually eased to limited daily curfew and business hours. The curfew is from 5 p.m. until 7 a.m. Partial educational process resumption. Some in the school grades from 7 to 12 are now enrolled, and only partially, like the governmental school. We have UNRWA system, and we have governmental system. UNRWA is dealing with refugees, with Palestinian refugees since 1948. It's a program. It's an organization or agency, a UN agency established in 1949 to respond to the massive displacement of the refugees, of Palestinian refugees, due to the Israeli occupation occurred in 1948, and also afterward taking over Gaza and West Bank and Jerusalem in 1967. So we can say that we have two somehow public servants, the government, and the UNRWA. And so for UNRWA schools, we are they are still frozen. There are no activities, only for students from 7th to 9th grade. We still have restriction in terms of PPEs usage, outdoor and indoor. Yet community is still coping with this, and I can say it's like the commitment to such PPEs, face masks, sanitizers, and other stuff is not is as much as 30%, I would say, among the community person. If we go to the third part, which about where do we stand now, perhaps I illustrated some, but just to go like it's a sort of I would say a halfway through. As you can see, from dealing with this crisis from March to November already is nearly 8 months. What we have is exhausted governmental and medical system. We have so many infected cases among doctors and nurses, which is really concerning now. We unfortunately still have lack of community commitment to PPEs, which is very much annoying and concerning. Aside from that, we have a devastated economy and the lack of funding and resources. Just now, Dr. Badrul mentioned that Malaysia is allocating like 1 billion ringgit for the coming year to deal with this crisis. What we have is far less than this amount, and because of the full siege and closure imposed, difficult to travel and to import and export goods, our economy is really in a very bad shape. With these circumstances, we surely have a shaking and changing situation day by day, sometimes even across the day itself. And so we have a deteriorated control measures because of the 4 things that I just mentioned. Now, to talk about adaptation and the strategies that was made by WHO, which is the final part. This is what we should have actually. We partially have some of these, but what we should have, and it can also be seen as a lessons learned. Support and empower the overall healthcare system, and further engage UNRWA and NGOs, international NGOs, not only at the provision of PCR, because currently somehow this is the case, but rather to increase medical staff, manpower, doctors and nurses, using some temporary employment means, strategically increase the number of random PCR tests, which is gone from like a few hundreds to almost 2,000 to 3,000 tests made per day inside the community and in a random manner. Gradually decrease the level of lockdown, which is what we have now, because from our experience, full lockdown is really severely damaging the economy. So what we need is more like a manageable, even flexible lockdown. We cannot say a full lockdown. And impose it for the classified areas as red zone, where there are so many infected cases. Sustain controlling measures that limit the people gathering and number of persons presented per closed and open areas, like malls, markets, barber shops, bakeries, etc., even educational institutes as well. Finally, the last 3 points for this strategy. Spread and dissemination of protective means, healthy use and practice at the community level to reduce and mitigate infection. It is somehow partially done. Sustain the closure of the mosque, weddings, wedding halls, weekly markets, and any gathering places until further notice. In fact, for the past 2 weeks, the mosques were reopened, although the wedding halls were not. But still, we still have some recorded cases, some witnessed cases in the mosque, inside some mosques, and they are some of them are closed for like 48 hours and then reopen. Sustain and establish and adopt a new strategy for public transportation, which is yet to be applied. Not only by committing to the use of PPEs, which is the case now. Most of the drivers do use masks, also some the passengers as well. But it cannot be only this part. We need also to reduce the number of passengers in the buses and in sedan vehicles. In Gaza, it is really common to use sedan vehicles instead of buses. As far as I know, buses are still not allowed to practice public transportation, but sedan vehicles are, and the commitment is really deteriorating, to say so. So this is what I wanted to share with you in the form of the platform I was talking about, which is the lessons learned about the COVID-19 experience in Gaza. I thank you very much for your kind listening, and will surely be open for any questions afterward. Thank you very much.
Okay, thank you very much, Dr. Azam, for your very precise, interesting sharing with us. Due to the time constraint, I think we should go for the next speaker. Thank you, Dr. Azam. Okay, we proceed with our third speaker, who is from Malaysia. Unfortunately, Dr. Razat Hadiyun is not able to be us today due to his important role directly managing the COVID-19 in Malaysia. I believe he's now at the side of our DG, preparing for the press statement. However, we already have his talk recorded to make this day more fruitful and engaging. Some info about Dr. Rohaizat. He's a re-employed, retired Deputy Director General of Health Medical Ministry of Health Malaysia. He's expert in health management and health economics and financing, and has been served the nation for more than 33 years. He's write several books for like health in Malaysia, achievement and challenges, and others. And yeah, he has a long CV indeed. Therefore, I think we go straight and watch Dr. Rohaizat's recorded video with the title of the Innovation in Global Health. The sound might be better at the middle recording. Okay, so please bear with us. Okay, thank you.
Assalamualaikum warahmatullahi wabarakatuh, and very good morning. Chairperson, Associate Professor Dr. Muhammad Hasni Jaafar, Senior Medical Lecturer, Department of Community Health, National University of Malaysia, UKM, panelists from University of Defence Malaysia, and also from National University of Malaysia, UKM, panelists from Islamic University of Gaza and Ministry of Palestine, learned speakers, lecturers, distinguished guests, ladies and gentlemen. It gives me a great pleasure and honor to be invited to deliver my topic on innovation in global health during this COVID-19 pandemic to all of you in this webinar. Ladies and gentlemen, in preparation for the pandemic, Malaysia has started early since end of December 2019 The first case of COVID-19 in Malaysia was detected on 24th of January 2020, and subsequently more cases were detected, mainly among travelers arriving from overseas, which formed the first wave of COVID-19 outbreak involving 22 cases in Malaysia. The second wave started on 27 February 2020, involving 651 cases, before the movement control order started on 18 March 2020. And now, Malaysia in her third wave of pandemic, which started on 20th September 2020. To battle this war, numerous efforts and collaborations between agencies were implemented. Some of the efforts taken by the public health programs, by the medical programs of the Ministry of Health Malaysia are: number one, we perform active case detection. Number two, we perform active contact tracing. And number three, aggressive quarantine and aggressive activity to isolate PUI, patient under investigation, quarantine, patient under surveillance, PUS, and we admit patients, including asymptomatic. In Malaysia, although patient is asymptomatic, we do admit and isolate them. Number four, identifying all the vulnerable groups, high-risk group, elderly people. Number five, mapping of cases, break down into the state, to the district, and also into sub-district. And we have four color-coded: the green, the yellow, the orange, and the red. Number six, we enhance the surveillance via ILI and SARI. ILI stand for the influenza like illnesses, and SARI stand for severe acute respiratory illnesses. And number seven, active disinfection and sanitization for the affected areas. And number eight, capitalize digital technology. And number nine, the border control. And then we implement the Act 342. This is Disease Control Act. And via this Act 342, Disease Control Act, MCO and other related activities were performed. And there are many other activities. I just mentioned some of them. There are altogether about 18 activities. What are the main strategies with regard to hospital services? What are the main strategies? So there are four main strategies pertaining to hospital services. Four main strategies. Number one, clinical care for COVID-19 patients. Number two, we protect healthcare workers. Number three, service continuity for both COVID and non-COVID, and particularly we must make sure non-COVID cases be given adequate treatment. And number four, we have to ensure, we have to help improve the economy and make sure or help to reduce the impact of COVID-19 to the economy. Let me go back to the strategy number one, i.e. clinical care for COVID-19 patients. Activities were carried out. For example, number one, improve the cure rate. We improved the cure rate. Until yesterday, our cure rate was 73%, and our mortality rate is very low, i.e. 0.7%. And under this, number one, the first strategy, we have many other sub-strategies like capacity planning for the facility, medical equipment and supply, PPE, lab support, infection prevention control, human resource planning and mobilization, develop treatment protocol and various guidelines. We have performed the mortality reviews, although our death rate is low, 0.7%. And number two, which is very important, protect healthcare workers, must increase their morale. And then we have the workplace preventive measures, the occupational safety and health (OSH) management plan, IPC infection prevention control management plan, the PPE management, and then we developed the quarantine center specifically for our healthcare workers, and mobilization of healthcare workers to the needed areas, and then the psychological support. And we also develop SOP, return to work strategy. And with regard to the third main strategy, service continuity for non-COVID cases is also very, very important. We have to make sure in Malaysia that non-COVID cases still receive adequate treatment. We develop a lot of SOPs and guidelines, and then we outsource some of our non-COVID services to private sector, outsource the lab services to private sector, human resource mobilization, and also we receive the help from private sector. They loan the ventilators to the government, and many other activities that we do to ensure service continuity during the MCO and then post MCO. And number 4, which is very important to the economy of the country, is to ensure that we have to perform strategy number 1 well, strategy number 2 well, strategy number 3, and following that we can enhance the economy of the country. And then we even perform during this COVID-19, the research and trial has been intensified, particularly pertaining to COVID-19. The health tourism, the medical tourism is still continue, and we still bring in foreign patients to Malaysia for treatment. However, when they come, they have to follow the strict protocol. Nevertheless, innovations plays an important role, and according to Information Week, the pandemic is having precisely the opposite effect when it comes to innovations. In fact, companies, universities, government, and individuals the world over have shown they can pivot rapidly, take significant risks, and innovate in unexpected ways. And ladies and gentlemen, Malaysia has not fallen far behind from other countries when it comes to innovation and during this pandemic. Various innovations have been introduced in fighting this pandemic, and I would like to draw your attention to various innovations that we have created. Number 1 is our homegrown apps, what we call it My Sejahtera, MY Sejahtera. My stand for Malaysia, Sejahtera mean for harmony, mean for peace. And this My Sejahtera is an application that have been developed strategically with multi-agencies involvement. We have the National Security Council involved with the My Sejahtera, the Ministry of Health, the Malaysian Administrative Modernisation and Management Planning Unit, MAMPU, and also the Malaysian Communication and Multimedia Commission, MCMC, and also Ministry of Science, Technology and Innovation participated in development of this homegrown apps. And this application is developed to, number 1, assist government in managing and mitigating COVID-19 outbreak. Number 2, help users in monitoring their health throughout the COVID-19 outbreak. And number 3, assist users in getting treatment if they are infected with COVID-19. And number 4, locates nearest hospitals and clinic for COVID-19 screening and COVID-19 treatment. And second innovation is our hospital, which is also known as the Low Risk Quarantine and Treatment Center, or what we call it MAEP Hospital, MAEPS Hospital. This is MAEP is the short form of the Malaysian Agricultural Expo Park Center Hospital, and this hospital is brainchild of the Honorable Prime Minister entailed multi-agency collaboration. And throughout the duration of the center's operation, this hospital MAP operation, many milestones were achieved and history was made. The completion of this 600-bed hospital only took 3 days to be completed. And the capacity can be extended from 600 beds to 1,000 beds. And from its earlier intention to be a step-down care, it was started to accept fresh cases, fresh COVID-19 cases, and eventually was converted to house immigration detainees from various immigration depots which were affected, particularly during the second wave of COVID-19 pandemic. And it was open its doors for business, for the operation, start officially perform the operations officially on 16 April 2020. And it managed to treat 1,362 patients, of which 94% were males, and then also 69% were illegal immigrants. And we have at that time total workforce of 1,157 personnel from various agencies. And 665 were medical personnel, 665 were medical personnel, and 492 were security personnel on a rotational basis been posted to this hospital. The center or this hospital also deployed various new technologies in its everyday operation. For example, it has robotics technology to assist in food serving to the patient. Number 2, electronic medical record, inpatient medical record management, and also thermal and optical scanner for staff surveillance. And this hospital or this center was officially closed on 15 July 2020, leaving behind all the sweet memories and invaluable experience for the personnel who had the privilege to be part of the history it was created. The third innovation is makeshift hospital, M-A-K-E, makeshift, S-H-I-F-T, makeshift hospital in the prison or in the detention center to cater for inmates that are positive COVID-19 cases. Meaning we convert this prison or detention center and make it to be a hospital, what we call it makeshift hospital. This makeshift hospital is a collaboration with Ministry of Defence and the National Disaster Agency Malaysia, NADMA. And this hospital has the capacity of 250 beds to treat the COVID-19 patient. And number 4, we also developed a field hospital and to be used for non-COVID patient. And this hospital also was completed within less than 3 days. And this hospital was a collaboration also with the Ministry of Defence and National Disaster Agency of Malaysia. This hospital has the capacity of 100 beds. It has ICU, it has the OT for operations, and it has the capacity to treat pediatric as well as ONG cases. Number 4, the development of, this is number 5, the development of electronic monitoring system. And before the pandemic, the data collection was done using manual system, i.e. the spreadsheet. But now during the pandemic, MOH has developed several dashboards to monitor the capacity and performance of various services, i.e. the hospital bed capacity, PPEs, ICU, and ventilators, as well as the lab services. Yeah, and there are many other innovations that have been developed, have been created during this pandemic. including, I mentioned to you earlier, the outsourcing of the treatment of non-COVID cases to private hospital, and then lab services to private hospital. We develop virtual clinic. We also have what we call extended clinic hours, and then many other innovations. Yeah. Finally, ladies and gentlemen, I'd like to thank the organizer, i.e. the Department of Community Health, National University of Malaysia, UKM, and all other speakers and panel members. Their presence have been invaluable and without any doubt has helped make the event a great success. We are also grateful to all those who have been involved in the organization of this event. Thank you.
Okay, thank you very much to the technical officer, Cik Zazman. I apologize for the sound just now, not that very good, but the end become better. Anyway, it's a very informative, it's just innovative talk. We'd like to thank Datuk Rezat for the pre-recording video just now. Okay, so let's we go to the next speaker. He's one of the speaker from Palestine. Okay? I would like to welcome Dr. Samer Abuza from Ministry of Health, Gaza, Palestine. Dr. Samer served as a environmental and public health officer at the Palestinian Ministry of Health since 2016. He received PhD in environmental health engineering from Tehran University of Medical Sciences in 2019. And he just come back from the University of Montreal, Canada after his the research visiting fellowship. His interest in microbial risk assessment, especially in the drinking water, environmental modeling, synthesis, and application of the nano material technology. He been works with the local and international agency in the past 40 years ago. With that, I would like to invite Dr. Samer to deliver his talk about cultivating resilience in global health. Dr. Samer, it's yours. Dr. Samer? Let's see. It's online. Hello, Dr. Samer, can you hear me? Yeah, Dr. Samer?
Yes, yes.
Yeah, Samer.
Dr. Muhammad, Dr. Samer is trying to unmute his mic, but it's not working. I don't know why.
Okay, I try.
Yeah. Make him a host, maybe.
Zazman, can you do that? Zazman, can you help?
Tak boleh cuba sekali lagi, Prof.
Can Dr. Samer, can you restart again? You have to refresh. Yeah, see, I can see you, Dr. Samer. I mean, can see you're there.
Yeah.
Yeah.
Yeah, it's okay.
Can you
It's clear
join?
now?
Yeah. Yeah, great. Yeah, okay. Okay,
Can
please.
you hear me?
Okay, great.
Okay, thank you.
Can you
Sorry.
share your slide? Yes. Okay, great. Can you back then?
Okay.
Okay.
Thank you so much. I'm sorry. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Let me begin by thanking our Malaysian colleagues for organizing important international webinar on sharing knowledge and experience, an approach for the global health resilience. Indeed, initiatives like this actually play a vital role in raising knowledge, connecting stakeholders, driving policy, and encouraging collaboration. So I am delighted to be a part of today's important webinar. And I hope that you and your families are all doing well in these difficult circumstances. In today's presentation, I'm hoping to give you an update on the strengthening health system resilience, key concepts and strategies to dealing with COVID-19 and future shocks. Catastrophic events occurring over the last decade have highlighted the need to understand how to govern health systems in the face of extreme and largely unforeseen disturbances or shocks. In high-income countries, this has been triggered by the economic crisis, and in low and middle-income countries, by the sudden outbreaks of infectious diseases like Ebola, as well as civil conflicts, with catastrophic consequences. Most recently, the emergence and rapid spread of novel coronavirus disease since the late 2019 has been severely testing health systems around the world or interact with other crises, economic migration crisis. National responses have varied greatly, with some countries more successful than others in containing the transmission and preventing death. Nevertheless, health systems in many countries, such as Italy, have found themselves struggling to cope with the exponentially accelerating number of cases, while health systems in other countries have also come or are coming under a huge pressure. Analysts are thus trying to draw lessons from health systems that proved more successful dealing with 19 cases, and to offer this best practice to health systems that are under strain. At the same time, questions are asked about what we can learn from the responses to COVID-19 and how to prepare for cope with similar shocks in future. The concept of resilience promises to be useful in answering these questions. However, the mushrooming literature on resilience remains confusing over time, and there has been a critique for the concept for being emphasized, although strategically useful, such as inevitable and healthy, as a rich concept like resilience spills over into health system thinking and health systems performance assessment. Nevertheless, it can create confusion for seeking to utilize the concept for policymaking in order to govern and monitor health systems performance better. We start by acknowledging that the understanding of this term, resilience, has broadened over the years and propose a narrower and more operationally useful definition that focuses on health systems' ability to prepare, manage, and learn from shocks. We consider shocks to be sudden and extreme disturbances, such as epidemics, distinguishing them from more chronic health system strains, such as those caused by population aging and relate key aspects of resilience to different stages of the shock cycle. What is health systems resilience? It is commonly understood to be the capacity to recover quickly from difficulties, toughness, or in reference to materials of resilience is far from a new and real, ranging from physics to human psychology. Okay, research response to health emerging societal shocks, severe and acute shock, and how the system can absorb and transform to with changes.
Oh, I think his line not that very good. And Dr. Samir?
I think his
Cut off,
line is off. Yeah, he's
Uh,
off. But he will come back for sure. Maybe there's an electricity problem.
Okay.
Can we give him like 2 or 3 minutes?
Sure.
Yep.
Maybe he can off his video because that make the audio better. Wait for him. Want to be there.
Yeah, sure.
Zalman, can you upload the Dr. Samir slide? Can we control from UKM?
I think that Dr. Samir is trying to enter, if I'm not mistaken. Yeah. Oh yeah. Now he's in. I think.
I can't see. Maybe we can switch him after the next speaker, maybe.
Yeah. I don't know. You can maybe call
I
upon
think we call upon the next speaker. We hold the Dr. Samir after this.
Yeah,
okay,
sure.
Sorry for the inconvenience for the other audience. Dr. Samir from Palestine have the internet line. I mean, the problem.
Yeah, I am here. I'm sorry.
Oh, you're
I
here
am
now.
sorry, the internet is interrupted.
Okay.
This is Gaza.
Yeah. We understand. I think maybe you off your video, just with the audio only. Maybe,
Okay.
I think the video take more back there. Yep. Can you look back your slide just now?
Yeah, let me share. Okay. Just share. Okay. That's great. So, looking at the stages of
nothing yet, Dr. Samir. Nothing.
Yes,
Yeah, okay, great. Okay. Continue. Sorry.
is it okay?
Yeah, okay. Continue, Dr. Samir.
So, looking at this, the stages of the shock cycle can help identify opportunities for enhancing resilience. Several stages or 4 stages can be distinguished within a shock cycle, which I summarized in this figure. Stage 1, preparedness of health systems to shock. This stage is related to how open or vulnerable a system is to shock. It is the stage that offers the greatest scope for action and a time when much can be done to strengthen a health system as well as to consolidate existing resources. Overall, the better the performance of health system, the more resilient it is. Stage number 2, shock onset and alert. In this stage, the focus is on timely identification of the onset and type of the shock, which requires robust and comprehensive surveillance and early warning systems. Clearly, the earlier it is realized that a shock is occurring, the faster and more effective the response can be. Stage number 3, shock impact and management. As the shock impacts a health system and society at large, the response falls within the more traditional kingdom of resilience. Absorption, adaptation, and transformation. Absorption relates to experiencing the system shock, but protecting the health system from profound resources imbalance by making available additional resources, either from reserves or contingency planning. Adaptation requires absorption, the additional demand or reduced supply, or both, by making the system more efficient. When adaptation is not working, or when all easy efficiencies have been made, the system will need to change more fundamentally to transform to cope with the impact of the shock. This may require a model radical rethinking of health system policy and the resourcing and delivery of care. The transformation process can sometimes compete with adaptation in relation to scarce governance capacity. Stage number 4, recovery and learning. This stage is the stage when the shock has disappeared and there is a return to some kind of normality. Despite the ending of the imbalance caused by the shock, there may still be significant changes to the system that are a legacy of the shock, so that the new normal is not like the old one. Health systems are complex. Shocks thus create complex and sometimes unforeseen consequences on health systems. A whole system approach is therefore needed to understand the ramifications of the shock in relation to the function of health systems and adopt the appropriate response. This figure explores a number of strategies for strengthening health systems resilience or for a resilient response to a shock. which we have distilled from the existing literature and emerging experiences of dealing with COVID-19. In this figure, I map them. Can you hear me again?
I can. Continue.
Okay.
We can hear you.
Okay. Okay. In this figure, I map them in relation to the key health systems functions and the stages in the shock cycle. Although we recognize that such distinctions are almost never clear-cut, and there are overlaps across stages as well as strategies. Indeed, in many instances, these are desirable characteristics for a health system at any time. Here, however, I deliberately choose attribute specific strategies to particular phases in the shock cycle in order to emphasize their increased relevance in these stages. The first health system function is governance, which includes 5 strategies strengthening health systems resilience, namely, first, effectiveness and participatory leadership with a strong vision and communication. Second, coordination of activities across government and key stakeholders. Third, organizational learning culture that is responsive to crisis. Fourth, effective information systems and flows. Fifth, surveillance enabling timely detection of shock and their impact. The second health system function is financing, which includes 4 strategies. First one, ensuring sufficient monetary resources in the system and flexibility to reallocate and inject extra funds. Second, ensuring stability of health system funding through counter-cyclical health system financing mechanisms and reserves. Fourth, purchasing of flexibility and reallocation of funding to meet changing needs. Fourth, comprehensive health coverage. The third health system function is resources, which includes 4 strategies, 4 strategies, appropriate level and distribution of human and physical resources. Second, ability to increase capacity to cope with sudden surge in demand. Third strategy is motivated and well supported fourth workforce. And the fourth health system function is service delivery, which includes 1 strategy, which is alternative and flexible approach to deliver care. Where relevant, I also provide examples of how these strategies have been used in real life, drawing on national experiences with the COVID-19 pandemic and other shocks. So the tables in the coming slides present examples of assessment areas grouped by resilience enhancing strategy. For example, the first strategy is about effective and participatory leadership with strong vision and communication. Here are some examples of how this strategy has been used in real life. First, set of contingency plans and protocols, emergency legislation, functional management capacity for governance, stakeholder participation and engagement, leadership steering and the clear chain of command, accountability of government agencies, effective governance structure, transparency, accountability, stakeholder involvement, a clear and visible plan for response measures, setting strategic direction, established public trust in response agencies, effective communication. The second strategy is about coordination of effectiveness across government and key stakeholders, which can be achieved by collaboration between actors, agreements with relevant actors, international agencies, non-state providers, NGOs, and so on, etc. Identifying measures of resilience. Actually, I'd like to continue with this table. You can read it. I will share the PowerPoint with you. Let me go. Okay. Before the conclusion, identifying measures of resilience is helpful to understand how well a country responds to crisis affecting its health system, establishing potential sources of vulnerability and planning for further actions. This can be done regularly, and methodologies for such evaluations have been suggested by the Organization of Economic Cooperation and Development in 2014 for the overall health system. In conclusion, the risk and frequency of shocks would appear to be increasing globally, whether from global warming, new epidemics, or economic uncertainty and changing geopolitics. It is important for policymakers to review their health systems, to regularly assess their resilience and address any possible weaknesses. In addition, identifying possible risks relevant to their health systems will be a useful next step, alongside highlighting which parts of the system are most susceptible to impact. Understanding the pathways of different shocks helps policymakers prepare for problems, but also manage them better. General health system strengthening will do much better prepare for and withstand shocks. Nevertheless, specific targeting of identified weak areas may not only help resilience, but also the overall health system performance. Thank you.
Okay, thank you, Dr. Shamil. Thank you for the talk about the cultivating resilience in the global health. We understand, I think Palestine is the most stressed country in the globe, because they have the disease and also the condition going on now. Okay, thank you, Dr. Shamil, for such informative sharing. Okay, Alhamdulillah, we next proceed to our next speaker. Is Dr. Muhammad Sharul Abdul Wahil. He's one of the outstanding PhD scholar at our department. His current study is on the urinary arsenic and autism. He was involved in managing one of the COVID-19 quarantine center in Keluang, one is in Johor during the second wave of pandemic. So the paper he's going to present today is actually the article that focus on the mortality reports. So I'll welcome Dr. Sharul to deliver your talk about the impact of traveling and mass gathering during COVID-19. Okay, the mic is yours.
Hello.
Yeah, silakan continue.
Okay, good writer, Associate Professor Dr. Muhammad Hasni Jaafar. First of all, I would like to express thanks and appreciation to the organizer for inviting me to this international webinar. It's a pleasure to meet with the respected speakers and the audience. So I would like to start my presentation entitled The Impact of Mass Gathering and Traveling Overseas Toward COVID-19 Mortality During Second Wave Outbreak in Malaysia. Throughout this presentation, I would like to highlight more about the finding of our study. But first, we will talk about COVID-19 in Malaysia as introduction, followed by COVID-19 mortality trend in Malaysia, and then major risk factors of COVID-19, how epidemiological risk factors affecting COVID-19 mortalities in Malaysia, and next, issue with mass gathering and traveling, and last but not least, public health intervention of COVID-19 in Malaysia. Okay, Malaysia is a multiracial, multi-ethnicity, multicultural country located at the Southeast Asian nation, also a member of Western Pacific region. Malaysia has a population of 32 million in 2020. Malaysia was recognized by WHO as one of the countries that effectively fight the COVID-19 pandemic because the mortality rate of COVID-19 in Malaysia was persistently maintained between 1.4 to 1.7% during the second wave of the outbreak, lower compared to the other leading countries, and even lower mortality rate of 0.6% during the third outbreak. This figure shows the overall situation of COVID-19 in Malaysia until 13 November 2020. The first positive case was reported on 24th January 2020, involved a 40-year-old tourist come in a group tour from Wuhan, China, who visited Malaysia from Singapore. Cases increased abruptly in the early March following religious gathering, peaked in the early April and reduced in trend until mid-June 2020. The case remained low, in which two-digit number of cases for 3 months before it surged abruptly in September 2020. So the movement control order, also known as lockdown, was firstly implemented by the government on the 18th of March 2020 and went through a series of different kinds of lockdown, namely conditional CMO, recovery MCO, enhanced MCO, with different objective, approaches, and implementation. Okay, a total of 22 positive cases was declared by Ministry of Health Malaysia as the first wave of outbreak, but no mortality reported. However, a sudden rise of new positive cases related to religious gathering, which later formed the second wave of outbreak. A total of 7,163 new cases was reported with significant number of mortality cases. This figure shows the trend of daily COVID-19 mortality throughout the second wave. The peak of mortality was in the beginning of the implementation of the MCO and reduced subsequently, signifies the effectiveness of the lockdown to cut off the chain of transmission and therefore reduce the morbidity and mortality of COVID-19. Okay, this figure shows the number of COVID-19 mortality cases according to state, where Kuala Lumpur, capital of Malaysia, recorded the highest number of COVID-19 mortality cases, followed by Johor State and Sarawak. And the rest of the states reported less than 10 mortality cases, including 0 case from Perlis, Kedah, and Kelantan. Okay, from the study, majority of the COVID-19 mortality cases were elderly and male and average age, and the ratio of male to female was 3.5 to 1. As for the major risk factors, 43% of them had diabetes mellitus, and about half of them had hypertension, and 31% of them had a cardiovascular disease. A very few numbers of patients had cerebrovascular disease, lung disease, lung cancer, and extrapulmonary malignancy. Okay, in this study, survival time is defined as the duration of time in days counted from the day of admission to the hospital till the date of pronounced death. So the average survival time for COVID-19 mortality cases was approximately 12 days. One patient survived up to 52 days, but some of them passed away within 24 hours post-admission to the hospital. As we can see the figure B, 50% of the patients survived for at least 12 days, and the chance to survive more than 50 days was very low, which was less than 5%. Okay, the figure and the table shows the average of survival time between two groups for the risk factors. So in this case is mass gathering. It was observed that the group that were related to the mass gathering had shorter time to death as compared to group who were not. The figure and the table show the same test as the previous slide. So the group who were related to traveling overseas had a shorter time to death compared to those who were not, and the findings were significant for both risk factors. Okay, the regression analysis in the tables shows the likelihood to have a shorter time to death for each risk factor. Even after consideration of other risk factors, the mass gathering was found to be significant to cause a shorter time to death. When we talk about mass gathering, it can occur as a result of proper human planning, such as religious event, social event, sports events, political events, economical events, or it can occur spontaneously due to natural disaster, where a mass evacuation takes place during the planned event. Issue with mass gathering and traveling. Mass gathering have no doubt contributed to the spread of the infectious disease. The mass gathering is not only about how people make close contact, but it also emphasizes on the huge number of humans involved, the limited and confined space, and how people are connected with each other. The movement of people across the geography would intensify the spread of COVID-19. Because COVID-19 mortality could be due to virological factor, as the emergence of more virulent virus was identified to infect certain countries, as reported by several viral genetic studies. Malaysia has put a lot of effort to combat and fight with COVID-19 pandemic. In order to cut the chain of transmission in the population, human movement and migration should be restricted. Malaysia has implemented Prevention and Control of Infectious Disease Act 1988 and the Police Act 1967 to declare the MCO or lockdown to the whole nation, which involve multi-agencies, which is led by the National Security Council directly under the Prime Minister Office. The government also has developed a specific and detailed standard operation procedure SOP to minimize the risk of transmission of COVID-19 in the population. Okay, at the moment, the COVID-19 has no definitive cure, but the main game plan is to reduce the transmission. The morbidity and mortality depends on the public health prevention and control of the disease. So in primary prevention, during the lockdown, travel restriction across the country, state, district was enforced, and the border security enforcement was enhanced, involved multi-agencies to prevent the unnecessary and illegal influx of the foreigner from the other countries. Other than that, the work from home order was initiated by the government, especially for those who work in the non-critical sectors. all form of gathering was prohibited during the MCOs. However, during the conditional MCOs, gathering event was allowed and restricted to only 250 people at a time. In the secondary prevention, the activity of screening and sampling is enhanced at the international entrance. The traveler who fly from overseas or from higher risk area domestically should be quarantined in the designated quarantine station for 14 days. In other words, they can't be quarantined at home. The Health District Office team also do a contact tracing from a positive cases, especially related to mass gathering. For example, following a religious gathering that was held in a mosque in Sri Petaling, Kuala Lumpur, which was attended by 16,000 people, a total of 42,000 individuals have been screened. And of these, 3,375 were reported as positive. In the tertiary prevention in Malaysia, for the management of COVID-19 patients, all positive cases in Malaysia were required to be admitted to the designated hospital for treatment and isolation, regardless of the severity of the disease. Malaysia has taken immediate action in February 2020 and drastically upgraded the health facilities and diagnostic capacity during the peak of the outbreak. For example, there was about 86% increment in the diagnostic lab capacity, about 90% increment in the ICU bed, and 49% increase in the number of available ventilators. So for take-home message, the prevention and control signify a major step taken by the government to contain COVID-19 pandemic, which has been deemed the main reason behind a decrease in the new cases as well as mortality cases during second wave of outbreak. The mass gathering and traveling history were the important epidemiological risk factors that need to be considered beside the major risk factor to be related with COVID-19 mortality. Okay, we don't actually continue until the third wave because of the ongoing pandemic and mortality. We actually have planned to extend the number of mortality cases into the third wave because maybe there is a possibility that a sudden surge of the new positive cases and mortality cases could be due to human movement and mass gathering event. As of 18 November 2020, which is yesterday, Sabah has recorded 24,269 cases and 181 deaths. With that, thank you.
Okay, thank you very much, Dr. Sharul. It's very fruitful sharing about this mass gathering and traveling is among the risk factor for the COVID-19 spread in Malaysia. Okay, thank you very much again. Okay, our last speaker, last but not least, is from Palestine. We are very grateful to have with us today Professor Dr. Abdul Rauf A. El-Manama from the Faculty of Health Sciences, Islamic University of Gaza, Palestine. Brief info about Professor. He obtained his PhD degree in microbiology from Ain Al-Aqsa Joint Program in 2004. And he pursued a Master in Science in Microbiology, Philippines, 1993. And he got a Bachelor of Science in Medical Technology from Philippines also in 1990. He's appointed as a specialist trainer in the food microbiology and HACCP by the British Council. He teaches and wrote many books and articles actually in the seawater pollution, antibiotic resistance, and many more. He's one of the American Society Ambassador to Palestine, head of the Emergency Committee of the Islamic University of Gaza, and member of the Consultancy Committee of Corona in Gaza Strip. So no doubt Professor Abdul Rauf is the right person to share with us about the COVID-19 impact on microbial resistance with us today. Please welcome Professor Abdul Rauf.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.
First of all, I would like to thank the organizer for this opportunity. I will be presenting on the effect of COVID-19 pandemic on antimicrobial resistance. I'll try to also have focusing on the lessons learned from both experiences, the COVID-19 pandemic experience and from the AMR pandemic also experience. Almost every part of the world is struggling with COVID-19 pandemic. Meantime, various lessons are being learned. For example, how to prepare for the next pandemic. One of these pandemics, the ongoing antimicrobial resistance pandemic, which is at a global scale, has the potential to surpass and eclipse COVID-19. The forecast for 2050 is that yearly 10 million people will be dead because of the AMR. Also, a global economy loss of about $100 trillion yearly will be lost because of this problem. The main points of the presentation is the bright side of the COVID-19, which is strange. Someone is talking about the bright side of a COVID-19. The use of antimicrobials and AMR during COVID-19 and COVID-19 versus AMR. During the presentation, we have to remember that the fundamental importance of antibiotics that revolutionized modern medicine. No one can imagine that modern medicine could be possible without antibiotic. It saved millions of people's lives. The positive effects of COVID-19 could be summarized by the following points. It has an impact on the public understanding of infection prevention and control. Every corner in the world has launched awareness programs on infection prevention and control, improved hand washing techniques and social distancing and other intervention measures, which will contribute in preventing infection. Also, improved health intervention in the healthcare system has been implemented also worldwide. A momentum has been added to the improved public health knowledge regarding infection prevention and control, and this should really be maintained through education and advertising. The COVID-19 pandemic also has highlighted the importance of vaccination, the need of new functional antimicrobials and preserve older antimicrobials, as well as the necessity for supporting research into the understanding of control of infectious agents. So we have to dig deeper to understand the problem of antimicrobial resistance. We need to understand the complex interaction between bacterial and viral infections. Most of the errors in prescribing of antimicrobials is due to the inability to distinguish between bacterial and viral infection. Also, we are facing a greater problem of dumping tons of antibiotics into the wastewater, which reaches the environment. We really don't know what is the effect of these antibiotics residues on the environment. So we need to dig deeper on that issue. Any plan to minimize the antimicrobial resistance issue should include appropriate prescription, optimized use of antibiotics, improved quality of diagnosis and treatment, reducing and preventing infectious disease. This means less disease, less antibiotic, less use, so you preserve them more. We also need research, a research that will determine the extent of the problem through surveillance and a research to discover new antimicrobials. What is the connection between COVID-19 and antimicrobial resistance? When misdiagnosing bacterial infection as a viral one, you prescribe antibiotics. Bacterial infection could co-infect with COVID-19. Many of the dead victims of COVID-19 has secondary bacterial infection. Also, many countries has implemented the prophylactic use of antibiotic. Of course, this is not this is not the right choice. However, in countries where antibiotic is not prescription drug, everyone can obtain this antibiotic. Many people think that antibiotics are the super drug, therefore they take them as a prophylactic drugs. One of the studies that have has pinpointed that many COVID-19 individuals presenting with mild disease without pneumonia or even moderate disease with pneumonia receive antibiotic. And these numbers clearly illustrate the extent of the problem. 72 of the patients received antibiotic, while in fact only 8% of them have demonstrated superimposed bacterial or fungal infection. So the difference in number is very huge. 8% who really deserve to take antibiotic, instead 72% took antibiotics. Also, the azithromycin, which is now implemented in many countries' protocols, is not recommended by the WHO. Only it is recommended for clinical trials. A second point that contribute to the increase of using antibiotic is COVID-19 has caused increased hospital admission. Hospital admission will also increase the possibility of contracting a healthcare associated infection, which is more resistant to antibiotic, requiring more intensive treatment with antibiotics. COVID-19 has disrupted the health services. Every hospital, every personnel is now dedicated and focused on how to fight and to combat COVID-19. Thus, the other services have been affected. One of these services is chronic bacterial infections such as tuberculosis and the human immunodeficiency virus. This will also may contribute to drug resistance. Also, vaccination programs in many countries has been affected. This will increase the risk of future infection, which potentially leading to overuse of antimicrobials. Another potential threat, which is the use or the wide use of the biocidal agent. Everyone is now advised to use alcohol, to use chlorine to disinfect surfaces at home. There is a risk of selecting strains of bacteria that are resistant to such biocidal agent. So we will increase the capabilities of this microorganism. Instead of being only antibacterial or antibiotic resistant, now they are biocidal also resistant. Which is more serious, COVID-19 versus AMR? Of course, now the focus is on COVID-19, and the number of deaths has reached, I think, in less than 1 year, or almost 1 year, 1.3 million people. However, the short-term effect of COVID-19 may be higher in mortality, while the forecasted long-term effect of AMR will be higher than COVID-19. As we said earlier, that in 2050, 10 million people will die yearly from antimicrobial resistance. We have learned a lesson, a prominent lesson from the response to COVID-19. It was a really high-speed response. This could teach every country in the world that we can tackle AMR faster than we are doing right now. The response to COVID-19 need to be informed by lessons learned from studying the slow motion problem of AMR. One point before I go to the next slide that should stated earlier, that COVID-19 is only one virus. But when we are speaking about AMR, we are speaking about a wide range of microorganisms, a range that really cannot be tackled in one effort, only one like that one of COVID-19. In a quick comparison, we can say that 54 million or maybe higher of COVID victims, while AMR only 64.5 million annually. Knowledge of the problem are developing for COVID-19, while for AMR it is well established. The spread is very fast for COVID-19, while AMR is gradual spread. The mechanism, everyone knows that COVID-19 has transferred from non-human to a human host and then from human to human, while AMR can be transferred from human, animals, and the environment. So it has a wider range of transmission. Also, behavior change required in COVID-19, the hand washing, the physical distancing, the travel restriction, and the quarantine. We can notice that both COVID-19 and AMR require this behavior change. However, in COVID-19, we have the quarantine perfect, but in AMR, most of the country do not make quarantine for people who are carrying or infected with AMR pathogen. The mortality, as we said earlier, it is 1.3 million. We don't know the annual loss for COVID-19. However, for the AMR, right now, we are close to 1 million yearly. The economic impact, surely till this moment, we don't know exactly the economical impact, which is very huge and as expected by all people. AMR is about 400 billion per year. The health inequity is increased in both in COVID-19 and AMR. COVID-19 related antimicrobial resistance challenges and opportunities. One of the challenges is that all resources were directed away from AMR surveillance toward the COVID-19. Increase in preemptive antibiotic prescribing to prevent secondary bacterial infection. This is very dangerous point. Antibiotic overuse in agribusiness, which is very common now. Delay in AMR legislation. In Palestine, we don't have any legislation about the use of antibiotic. Antimicrobial drug shortage. The USA, United States of America, has withdrawn support of the World Health Organization, which is the main key player in AMR fighting. There's a low public awareness of antimicrobial resistance, and everyone is so tired because of the COVID-19. This is a very huge challenge to the whole world. The opportunities, we can still benefit from supporting hospital AMR surveillance system, developing antimicrobial stewardship programs, develop and use rapid diagnostics, embrace One Health approach, which is really very helpful in fighting antimicrobial resistance, since this One Health approach close the gaps between animal, human, and the environment. Okay. At the end of this presentation, we really recommend that legislations are passed, encouraging new antibiotics and other promising anti-infective agents. We have to strengthen the global cooperation and governance architecture, develop collaborative public information campaigns, leverage the infection control principle from COVID-19 experience. So COVID-19 has some input on the efforts of AMR combating. It is a wake-up call that collaboration is the most effective way to tackle global health threat, and one of these threats is the antimicrobial resistance. Thank you so much for listening.
Thank you very much, Prof, for this great talk. Thank you. And yeah, now we are at the Q&A session. We have finished all the 6 speakers. I would like to open to the audience if there is any question verbally. Anybody want to ask question? Yes, Aiza, please. Chaza, you want to ask? You can ask now. Please identify yourself. I'm sorry. Introduce yourself and you're from where? Sorry. Chaza? Okay, never mind. Can we go for the chat box? There is a few questions here. I think one question to Dr. Badrul from Dr. Azlan UPNM. Assalamualaikum, Dr. Badrul. Why does Malaysia regard we are now in our third wave of the pandemic, whereas the rest of the world say they are in the second wave? Why do we count the first wave consisting of only a handful of patients as a wave? Thank you, Dr. Azlan. Dr. Badrul, want to respond?
Okay, thank you very much, Dr. Hasni. Thank you to Dr. Azlan. He's my colleague actually at the National Defense University. Right. Actually, the first, second, and third waves of COVID-19 in Malaysia that I presented, if you notice, it is consistent with the one that presented by Dr. Sharul just now from UKM. So basically, we are in consistence with the announcement or the declaration by the Ministry of Health, in particular by the Director General of Health Malaysia himself. In addition to that, even though that the very first wave was small in comparison, I think just about 22 cases in total for the first wave. But the very first wave, the index case, so-called, was directly linked to the Chinese national from China. For example, for the second wave that I mentioned, as well as Dr. Sharul has mentioned, mainly related to the Sri Petaling Mosque gatherings. So those are different index case altogether from the first wave, whereby the index case was from China. And after the first wave, basically we were settling down. Only we experienced the second wave. And then at the current moment, we are in the third wave again, as announced by the DG of Health Malaysia in October this year. If we look at the US in comparison, I happen to be in the US actually in late February and early March, whereby they were not declaring any COVID-19 cases at that moment. Only soon after that, starting early March 2020, then the US really had a surge of their COVID-19 cases, and it extended exponentially, obviously, until today. Some of the observers worldwide, they still regard what happened in the US, for example, as a very prolonged first wave still. And what worrying most, be it in the US, in Europe in particular, because they are experiencing winter season at the moment. And we learn from past experience, for example, of the influenza, the seasonal influenza. Really during this winter season, there'll be a surge in the number of influenza cases. So that is why they are worrying most on this coming winter season, which they regard as the incoming second wave to them, but not to us in Malaysia. That's my response. Thank you.
Okay. Maybe we can also ask Dr. Azam how the Palestine, is it Palestine also have the 3 wave or just 2 wave? Dr. Azam?
Well, actually, it's hard to name it as wave or see it as wave actually, or waves.
Okay.
Just like what I mentioned, the event if we talk about Palestine, there's West Bank and Gaza Strip, so they are like two different places when it comes to COVID-19. In West Bank, it was hit by COVID-19 just like Jordan, for example. So and Israel as well, because Israel was hit badly at the beginning of the COVID-19, like mostly January 2020, January and February as well. So there was like all of a sudden tens of cases spreading across the place. Whereas in Gaza, by end of March, we had the first 2 cases. And by the way, coming from Pakistan, 2 members of Dawah and Tabligh, they were in a conference in Pakistan. And I believe some of these sheikh, they were also from Malaysia, you know, and it's ironic, but it happened, you know, like we had somehow the same experience.
Yeah.
But yeah, luckily what we have is 2 cases on the borders, so they were quarantined and then for a while, and then also by that time in March, all travelers or returnees were quarantined, like for 14 to 21 days, and they were tested and investigated. So it cannot be seen as wave, you know. What we had in August, it was actually what we were expecting, that some cases will slip, you know, from the borders and go undetected. And then, so by August, we were having inside the community cases. And ever since, it was like increasing, like in daily basis, going from tens to now hundreds. So maybe with winter coming in, just like Europe, just like all the region, inshallah, this will not happen, but this is what we are expecting, just like the others. Somehow, some more aggressive way or more aggressive wave to hit by next month, by December or by January, as this is between bracket the season, the influenza season, the season where you know the weather is very cold and we get the people get sick and ill because of this, because of number of viruses coming out similar to coronavirus. So perhaps if we are to say the second wave, then the second wave is not happening yet. Mostly, if it is going to happen, then perhaps next month or January, and hopefully it doesn't happen at all.
Okay, Dr. Azam, this is the second question from Dr. Daniel Unimas. He's one of the university at the Malaysia. Assalamualaikum, Dr. Azam. Any help given by the Israel? Any attack happened during this pandemic? Okay.
Yeah, I will answer that. Actually, our relationship with Israel is really complicated. It is an occupation authority that is ruling everything, controlling the borders, controlling what is going in and out in both sides, in Gaza and West Bank. Yes, physically in Gaza, there are no troops, no Israeli forces among the cities, inside our cities. But in West Bank, things are even worse. Israeli army go in and out easily at any time with or without coordination with the Palestinian Authority. So they control everything. And so if we are to talk about help, what they do is they ease, let's say, in Gaza, they ease the entrance of the international help and aid coming from outside. They don't really physically help us. They don't support us or fund us, you know. I may say there are some kind of support in terms of referral cases. Like if we have complicated cases in here, we may refer them to some Israeli hospitals. This can be seen as some sort of help, I would say. In the West Bank, things are different because of the geographical differences. The cities in the West Bank are side by side with the settlements, with the Israeli so-called Israeli cities. So there is some kind of help and support and coordination in such term and in such crisis, because of course what hits West Bank hits also Israel and vice versa. Unfortunately, there were some attacks by warplanes, by Israeli warplanes, sometimes as a retaliation for some rockets going out from Gaza, sometimes due to the disputes between the local authorities and local government here and there. Still, it's an occupation force, and it's controlling everything around us. Yet they don't really provide the support. They just ease, let's say, the support coming from international community and from WHO and international NGOs.
Okay, thank you. Okay, I have one question to Prof. Abdul, since he's the only microbiologist here. Thank you very much about the antimicrobial resistance. I wonder about the vaccine now. We're talking so much been now producing, I mean, in the state of producing in China, the Russia, and the US. And as far we know that in the what call that, to produce any medicine or drug, for example, for the research protocol, it takes years to produce such effective medicine. But what your opinion, Prof, on this vaccine production now? Is it will be effective or not? Yeah.
There's a question about the reproductive value.
That later, you know.
And the herd immunity. I prefer to answer that.
Okay, you want to refer? Okay, you can answer the first.
Okay, the reproductive value for the virus is ranging from 2 to 4 in different places and in different settings. About the herd immunity, it is really difficult to predict now because when we calculated the number of infected people worldwide, it constituted less than 1% of the whole population. So the 56 million is only 1% or less than 1% of the 7.8 billion people on the planet. Therefore, to reach an herd immunity with an R naught 2 to 4, you require at least 60 to 70% of the population to be immunized. And this is really very far away from the truth, reality. And the vaccine that every now and then we are hearing that there was a vaccine that has been produced in US or in Germany or in China or in Russia. None of these vaccines has been given a final approval. Zero vaccine final approval. So we are really sticking to the preventive measures as the main mean for preventing or fighting the COVID-19 pandemic. Thank you.
Okay. Thank you. We have this question, I think, from Dr. Punita. I think this should be answered by Dr. Sharul. Badrul, sorry, Badrul. Sharul, you are a student, apa lagi? So we ask Dr. Badrul, is experienced with the KKM. What are the factors known to ensure we are on the right track to flatten the curve and eventually outcome this pandemic in Malaysia? Any specific prediction model may use? Thank you.
Sorry, Doctor. I think I'm not in that position to answer that. Maybe I can
okay.
Dr. Badrul.
Dr. Badrul lah, Dr. Badrul.
Dr. Badrul.
Okay. That's me, thank you, Dr. Punita. I'm afraid also I may not give a precise answers on that because the predictive model that used by the Ministry of Health Malaysia in-house is done by the National Institute of Health. Well, I am no longer in the Ministry of Health Malaysia, I'm afraid. They should be the one that know the a better answer for this. But anyway, from what I observed, they are not plays an important role. They are not that we just discussed just now. Whether are we on the right track to flatten the curve? Having said that, this is my own observation. I'm not too sure whether it is being included in our predictive model by NIH. Is the compliance to the SOP, which I think is very hard to measure. It's difficult to measure. Maybe Dr. Sharul and the team later on can have a look on this. Because to me is the strict compliance to SOPs, among others, namely stay in the house if you do not have an important business outside, and then comply wearing the face mask correctly. If you have to go to the crowded areas, to the confined spaces, for example, or you cannot avoid from having a short distance of physical contacts with others, and regular hand washing, as what has been advocated just now by Prof. Abdul Rauf as well. So in my observation, those compliance to the SOP will make a difference to our success rates in flattening the curve. But again, it's a challenge. I think if you were to put that, in a valid way in our predictive model. So I'm afraid I just can answer just some parts of that question. I get back to you, Dr. Hasni. Thank you.
Okay, thank you, Dr. Badrul. Yeah, there's a lot of uncertainty on that, right? Inshallah, we pray together. Then, yeah, we hope the pandemic will end soon. Okay, I think we now reach at the 35 minutes past 5. I think there's already 35 minutes past 12 there in Palestine. I think we are 30 minutes more exceeded our time. But anyway, it's very good session. If you look in the chat box, there is a link for the registration. Yeah, you can click there and you will get the e-certificate. We send you through your emails for the speakers and also for the participants. Okay, ladies and gentlemen, may I thank you very much for your active participation in this webinar. I hope you enjoyed the talk today. The webinar today should be a starting of collaboration in the smart partnership between Malaysia and Palestine in future, especially in the education, maybe research and also learning. By that, special time to all speakers, Prof. Dr. Abdul Rauf A.Al Manama. Thank you very much, sir. From the Faculty of Health Sciences. Dr. Azam, thank you very much. Dr. Samir already left, thank you also. To Dr. Raza Adiyun, Dr. Barisham and Dr. Muhammad Sharul, thank you very much. Jazakallah khair to webinar committee and those directly, indirectly involved in making this webinar successful. Okay, assalamualaikum and have a nice day.
Thank you.
Bye.
Bye. Oh my God.
Register.